This was actually one of my first research projects, distal radius fractures with you, when I was between my third and fourth year. So I'm glad to be here talking with you about this topic. I actually gave a talk 2 years ago on indications, so think of this as an extension of that. I have no disclosures or conflicts of interest. As we know, the distal radius fractures have a wide spectrum of fracture patterns. So the approach that we take and the way we plan ahead for them really requires a tailored approach to understand exactly what we're going to do with these. So in terms of like the three main objectives I want you to get out today is, first of all, why? Why and what do we want to fix? So I'm not going to go in depth into surgical indications, but I want to stress the point that your surgical indications really have to align with also your treatment goals and how you're going to approach this fracture. And then we get into the nitty-gritty. Once you've actually decided to fix and you've decided what you're going to fix, how are you going to do it, right? And this is the meat of the talk. And then finally, what else needs to be fixed? I won't go into this in much detail, but you also have to be aware that if there are other associated injuries, whether it's DRUJ, whether it is in the carpus itself, whether it's a distal ulnar fracture, that is also part of the plan, and that may also have an effect on the sequence of events as well as the implants that you have. So in terms of surgical indications, again, this is multifactorial. It depends on the patient factors, their age, their baseline function, their habits, their hand dominance, also their functional demands, right? What occupation are they going to do? What's their physical activity? Are they a professional musician, for example? All these things do matter to the patient's ultimate function and your surgical goals. Also, early mobility, whether this is a polytrauma patient, whether it will help them in the early postoperative period, if there are even short-term benefits. The treatment goals, as I said, should really align with their surgical goals, right? Is this a 75-year-old woman who has a baseline function but is not high activity? Is it a 20-year-old professional musician, right? All those will change not just your indications for surgery, but it will also affect exactly what you're going to try to accomplish with surgery itself. The fracture features to pay attention to are length and alignment, articular congruity, again, which one you're going to approach will depend on the patient, as well as the stability of the fracture itself. Okay. Your treatment goals should also consider the postoperative rehabilitation, right? Is your fixation going to allow them early range of motion or delayed range of motion? Is that tolerable? Is it a polytrauma patient? Are you going to improve their weight-bearing status? Are you going to have earlier return to work or activity, or is that not an issue whatsoever? So this is sort of the algorithm that I put in my mind. I think it's important as we're thinking about the planning and thinking about the approach to consider what's actually in your toolbox. And this will be different for each person, right? Depending on level of training as well as the type of implants you have. At one hospital, I may have access to every single implant under the sun. At another hospital, I may only have access to one company. So that's also an important consideration in terms of feasibility. When I'm looking at fixation types and I'm thinking about what kind of hardware I put in there, the first decision point in my mind that is whether or not I'm going to address the joint. Because then that sends me into whether I'm going to do something bridging or whether I'm going to actually go over the articular surface itself. And then that can break down a little bit further. I'll get into detail in a bit. In terms of imaging, right, we always try to reduce the fracture. Even if you know you're going to fix it, I think, as you taught me, every patient warrants some sort of reduction. Okay, you don't want them to be sitting in a malreduced position, even for soft tissue rest and patient comfort. This will give you a sense of the alignment. Sometimes gives you more information about the articular surface and how things would otherwise align, and it also gives you some idea about the comminution, how link stable this is. I think traction views, we don't always get, but sometimes they can give you some more information. So for example, on the left side, you see how much comminution there is and some impaction on the articular surface, but you put them into traction, you get a traction view, you can see actually the articular surface lines up pretty well. So even if I just restore the length or apply traction, that maybe this person would do okay and their articular comminution may not be that bad. Okay. In terms of advanced imaging, I don't always get it, but I'm looking at some things that are very specific. One, sometimes I'm looking at the articular displacement that comes down to your surgical indications. If I'm going back and forth or something looks a little bit weird at the joint. I'm looking at the size of articular fragments, and I'll get to that in a second because this may affect my fixation. And then, of course, I'm also looking for any other associated injuries, for example, like a non-displaced scaphoid fracture. Okay. This is one study from 2014, Journal of Hand Surgery, looking at why these fail, right? The most common mode of failure is that you lose fixation of the lunate facet and you have radiocarpal subluxation or instability. And so they actually measured this, and the threshold was sort of 15. for standard volar locking plates. So if that fragment was less than 15 millimeters, right, chances are you would not be able to capture that with your standard volar locking plate. Okay, and so this is sort of the benchmark that I use when determining whether or not I can do my standard fixation or whether I may need something a little bit more specific. Okay. In terms of looking at the specific types of fixation constructs, I break it down into a bridging construct versus plating construct. For bridging constructs, you can't really address articular surface, right? So for me, the main indications are related to metaphyseal comminution, articular comminution, but an unreconstructible joint, right? I'm not going to focus on the joint. My plate is going to affect the joint, and probably the patient, in terms of your treatment goals, won't miss it as much. Okay, the historical indication was about metaphyseal comminution, but to maintain length. But I also use this as a backup to maintain length or prevent collapse to supplement my fixation. Okay. In terms of ORIF, I think a lot of you who have treated these know that the volar locking plate, that's the main workhorse, right? But when I'm thinking about my fixation, I want to make sure that I'm capturing that lunate facet piece, right? Because if I don't, that puts me at risk for failure of my fixation. But you have to also realize that not every fracture pattern can be addressed with a standard volar locking plate, and certain patterns, especially that have a lot of comminution or small pieces, may require different implants or different approaches. So again, volar locking plate is your workhorse. There are also different plate designs too that may offer specific features for certain types of fractures. But once you get into the much smaller pieces and fractures like comminution, impaction, chauffeur's fractures, then you have to start thinking, do I need something else, something smaller that a standard volar locking plate cannot capture? There are limits, however, right? We don't do this for every single patient. You may need a second approach, may increase your risk of stiffness. Typically, these implants are much more rigid. They may consist of pins or just more thinner, smaller plates. And there's also a potentially higher complication rate compared to standard volar locking plate. So I'll just demonstrate this case that you saw earlier. A lot of comminution, very distal radius fracture, a blasted distal ulna. So distal ulna already, I'm like, oh, crap, I have to deal with this, okay? This is the CT scan. It was open as well. My partner actually managed it initially. This is the CT scan, and from the center view, you can actually see, even though there's a lot of comminution, that there's a large enough piece on the lunate facet that I can actually grab. So I'm thinking, I can actually reconstruct the joint. The image on the right also shows me the joint actually lines up pretty well. So in my mind, I can reconstruct this joint. Okay. The traction view also shows me that if I bring this out to length, that would be acceptable, right? So in terms of my plan, I'm actually going to do a hybrid model. I'm going to use a bridging construct to bring me out to length and supplement my fixation, because even though I can still reconstruct the joint, there's a lot of metaphyseal comminution that I'm worried may continue to collapse. But I can also reconstruct the joint, so I'm thinking some sort of plate fixation to get some sort of congruity there. The patient's also relatively young, so I want to make sure that I give them the best outcome. Okay? So I'm putting on a dorsal spanning plate, getting my overall length, getting my overall alignment. That actually looks pretty good. And then I'm using some K-wires as joysticks. I'm using a mini fragment plate to bring things back together and fine-tune my articular reduction. And then I'm putting my definitive fixation on top of that mini fragment plate to get the articular fixation intact. And then I'm dealing with my ulna, which was all its own story. And this is sort of the final result. But this also allows me to take out the plate, the dorsal spanning plate, earlier, because it's really not there for the fracture healing per se. It is there to supplement my fixation to prevent any sort of collapse. So that's all I have for you today. Happy to take questions afterwards.